Good afternoon, everybody, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm the chair of the Grand Rounds Committee. A couple of brief announcements. In order to receive credit for attending today's lecture, please complete the evaluation, which was sent in the Grand Rounds announcement on Monday by Karen Lambert, and there's a SurveyMonkey link there. Grand Rounds will be on Zoom for the rest of this academic year, but we are planning to do it again in person in the fall. But as prior to the pandemic, it will always be available on Zoom for people who are far away. If you have questions for today's speaker, please type them in the chat function at any time during the talk. I will ask the speaker the questions at the end of her talk. Next week's Grand Rounds on April 28th will be given by Dr. Richard Bailon. Dr. Bailon is professor of psychiatry and anesthesiology and associate chair for education at Wayne State University School of Medicine. And the title of Dr. Bailon's talk is Benzodiazepines Revisited. It's my pleasure today to introduce Dr. Yael Dvir in adolescent childhood. Dr. Dvir received her MD degree from Hadassah Medical School at Hebrew University in Jerusalem, and then came to Worcester to do her adult and child and adolescent psychiatry fellowship. She's currently an associate professor of psychiatry and pediatrics, and she's won many honors and awards, particularly for her activities in teaching. She's also in Best Doctors of America and won the semi-annual UMass Chan Medical School Medical Student Teaching Award in psychiatry. She has also held leadership positions in education. She was director of the medical student clerkship in psychiatry for many, many years, stopping that in 2021 because of other administrative activities she had to do. She's also found time to publish 23 peer-reviewed publications and 2 book chapters, and has given numerous invited presentations both internationally and nationally. So it's my pleasure to introduce Dr. Dvir. The title of her talk today is Access to Child Psychiatry, Challenges and Creative Solutions. Dr. Dvir.
Thank you, Tony. Let me just share my screen here. And can you all see the slides okay?
Yep.
Okay, so that was a kind introduction. I appreciate it, and it's always good to talk at my home base. I realized that the title of this talk is a little ambitious. There are many challenges to access to child psychiatry and many solutions, and I'm only presenting very small number of them, and specifically those that we have been using in the division. In terms of my disclosures, some up-to-date royalties and then funding for Bridging Clinic through a Community Health Fund Award, and funding for MCPAP for early childhood through MBHP, and these are federal funds that are going through DPH, no other disclosures, and those are programs that I'm going to be talking about. Outline of what I want to discuss today is a little bit of a background and the scope of the challenge in terms of access to child psychiatry, then describe some models of integration of child psychiatry and focus on MCPAP as one of those models that has been a successful one and used throughout the country. Talk a little bit about what we've been seeing throughout the pandemic with regards to MCPAP assessments, and then talk about the solutions we've had to some of the challenges here in our division, the Bridging Clinic, and then our MCPAP for early childhood that's been launched this fall. So learning objectives, to review the challenges and understand the models, and then appreciate what the impact of the pandemic was on some of our existing challenges. So starting with what really is the problem, it's always been a problem to provide the care that children and adolescents need in terms of behavioral health needs. And part of the issue is that if you look at statistics, there are 72.5 million children in the United States, and a little over 8,000 practicing child and adolescent psychiatrists. And I will say that this number, we don't know how accurate it is because it includes people that may or may not be doing other work that isn't clinical work. Either way, it is clearly not enough to address the needs. We know that about 13 to 20%, so about 1 in 6 children have some sort of mental, emotional, or behavioral health disorder every year. And only about 20% of those children will receive any care from a specialized mental health provider. And this includes, all of our affiliated professions, not only child psychiatrists, obviously, social workers, psychologists, everybody who's working in the field. So what does this mean? This means that we have a significant workforce shortage, and it is a persistent problem. So if you look at the map, we're actually in a geographical area that is only high shortage and not severe shortage, like the majority of the states. And although we are training about 850 new child psychiatrists each year, which is why training and education is important and makes a huge difference, it's still not predicted to be enough. And we are still not going to be able to meet the challenges and the needs that we predict are going to happen. So while we've increased the number of child psychiatrists by about 20% in the past 15 years, that is still not enough to meet the projected ACAP need for this. And this isn't something that is unknown. And just this December, the Surgeon General, Dr. Vivek Murthy, came out with a call for action about youth mental health crisis, and basically saying that even before the COVID-19 pandemic, mental health challenges have been pretty significant, and there has been a steady increase in challenges in youth. And if you look at, for example, I don't have this data here, but if you look at suicide rates, especially in children that are preteens, there has been a steady increase in the past 10 years. It has exacerbated during the pandemic, which caused significant unprecedented challenges and trauma and disruption to the daily lives of kids. There has been increase in anxiety, depression, lots of other mental health concerns, not to mention the fact that youth have been dealing with significant loss. It's also important to state that the pandemic has especially affected and impacted youth that are already vulnerable. So that includes youth that already have behavioral health conditions or intellectual and developmental disabilities, minority racial and ethnic groups, LGBTQ+ youth, families with low income, rural communities, kids that are involved with juvenile justice, foster care, kids that are runaway. So this has been a big challenge. And the call for action was basically to say that this is not something that only one part of society can address. This is something that requires action on multiple levels, from caregivers, from school, from health leaders, organizations in the community, media and technology companies also play a significant role in here, and we all have a role to play. So with this backdrop of the need, who are the people who get to manage most of the difficulties. These are primary care providers and primary care pediatricians. And this is data from the CDC from 2016 that showed that only about 1 in 3 pediatricians report that they have sufficient training to diagnose and treat children with mental health conditions. But the other piece of information is that they are the majority of prescribers for psychiatric medications in outpatient settings. So this brings us to behavioral health integration, and this is just an overview of a number of approaches and models of integration of behavioral care. So there is the consultative model where the psychiatrist sees the patient in consultation in their office. The referral is from the primary care. There is some communication, but it's away from the primary care, and the psychiatrist really manages the case independently. There is co-location where the psychiatrist and the primary care are located in the same practice, and it's more like a medical home, and the patient is managed by the psychiatrist in this setting. Then there is the collaborative model where the psychiatrist provides consultation on the caseload to primary care and works closely with primary care to manage the case. They may offer one-time consultation or stabilization, but the patient is primarily managed by the primary care. Now, MCPAP, which is what I'm going to be talking about in a little bit, is really a bit of a combination between consultative and collaborative model. I like to think about it as a little bit of a virtual co-location, and with bridging added to it, that adds a little bit more to that perspective. So MCPAP, which originated at UMass, is sort of the model for expanding pediatric mental health access. And right now, with the new Pediatric Mental Health Care Access that was part of the American Rescue Plan Act, there is expansion of those programs throughout the country. So as you can see in this map, the majority of states and territories now have a child psychiatry access program. There are programs that are established. These are the blue states on the map. There are programs that received fairly recent funding to start programs in 2018 through HRSA funding. And then there is the 2021 HRSA funding and programs that have been established and have additional funding for expansions, which is Massachusetts, and partly that is our program. So what is MCPAP as sort of a founding example of a child psychiatry access program? And I apologize for the drilling upstairs. I'm hoping you can hear me now. Okay.
We can.
Okay, because I could barely hear myself. So, so MCPAP is really more of a system of regional behavioral health consultation teams, and they're designed to help primary care providers and practices the behavioral health of their pediatric patients. And those are available to consult with the providers. And the goal is to help primary care providers both feel more comfortable and be able to manage more in their practices and stretch sort of the number of kids that can be helped by a child psychiatrist. So there are teams in Massachusetts. There are 3 regional teams. Our team is the Central Western team that is UMass and Bay State, which is a shared team. And each team has 2 full-time psychiatrists, can be pieces of psychiatrists, a behavioral health clinician. There is a resource and referral specialist and a program coordinator. So the history of MCPAP, for those who don't know, is that in 2003, it started as a pilot program here at UMass. And I don't know if Bill O'Brien and Mary Jeffers Terry are able to join today, but
they were part of that first targeted child psychiatry services model, which was enthusiastically adopted by the state. So the Massachusetts chapter of the American Academy of Pediatrics thought that this was a wonderful approach. And then in 2004, DMH through MBHP adapted the model and implemented it statewide. In 2015, there was some strategic planning and a report that looked at what are some ways to improve this program. So after about a decade, there have been some changes, and from this one program that started at UMass, we're now all across, there are over 30 states that have similar models and 47 that are growing to that. So it's really been a huge impact. This is some data on practices that are enrolled in MCPAP. So every primary care practice in the state is able to enroll in Massachusetts. There is no cost associated in the Massachusetts Child Psychiatry Access Program. There's no cost associated with enrollment. You can see that our central team at UMass has been consistently the largest team. Some of it is longevity, and other is the needs of our population and the more rural nature of our region. This is enrolled providers. Again, you can see that in Central Mass, we've probably gotten the biggest number of enrolled providers. This is about the goals of MCPAP. So this is a consultation and education model. And I think the bottom line is that we are not managing those patients for our pediatric colleagues. We are helping them managing their own patients, so they can put a call in if they have a question. They get a child psychiatrist to call them back within 15 minutes and give them an answer and just some advice. If during that conversation it's decided that a face-to-face evaluation is indicated, then a referral is made for that. But the MCPAP psychiatrist never prescribes. It also does not replace emergency services. This is meant to really be a virtual co-location and a shared management, and to help pediatricians feel like they own the care of their patients in terms of behavioral health. The care coordination and referral piece is also very important. The problem there is obviously we cannot be better than the resources available in the community. All we can do is try and connect families with the available resources in the community. MCPAP was designed to be a mild to moderate type of case consultation. So there are always going to be youth who will require child psychiatry care in different settings. It was not meant to replace that. And in terms of vision, the thought is beyond ownership, there is also going to be screening and confidence building in the ability to diagnose, treat, and make referrals for most common conditions. I have to say, from my perspective, Thursday morning is my time on the phones with MCPAP, and I so appreciate the questions that the pediatricians are calling to ask and the effort that they're putting into caring for their patients. And they really do buy into the model and understand that we can't possibly take care of every child that they have a question for, and that this is sort of a way to maximize the use of the resource. And it is helpful to know that we always have their back when they need us. So after that strategic planning in 2015, there was a MCPAP 2.0, and there were some changes. There were the creations of regional teams and some changes in how the program operates. There are also additional sub-specialized or offshoots for MCPAP. So there is Nancy Bias MCPAP for moms at Boston Children's Hospital, substance use and addiction program. There is a collaboration where youth that are struggling with substance use can receive, and families can receive consultation through there. And then there is MCPAP for autism spectrum disorder and intellectual disability, where Jean Fraser has been involved in the creation of this program and is the medical director of MCPAP for ASD-ID. In terms of what we've been seeing during the pandemic, so there has been a lot of data that looked at the increase in need for child psychiatry care, but it was mostly data about emergency room visits and inpatient admissions. There was not much published on what is happening in the community, and especially what primary care providers have been dealing with. And we looked at those numbers. So you can see that after an initial dip in numbers in early pandemic time, so spring of 2020, which is consistent with a dip in seeking medical care all around, 2021 has shown a significant increase in requested consultations from pediatricians and primary care providers. We did see that for the most part, and I will just say that the left column of the March and April of 2018 and 2019, these are 2 years. So if you look at the numbers, you can kind of roughly divide it by half to imagine what would be the number in a typical year. But there's been a significant increase in referrals. And what we saw is, in terms of diagnosis, the most significant increase was for youth with autism spectrum disorder. So it was 165% of the numbers for the prior year. And that was followed closely by anxiety and depression, which was 43% increase. And it really reflects some of the trends that there has been a lot of increase in anxiety and depression, and what we said about vulnerable populations requiring more help. Some of this, especially for the autism spectrum disorder youth, is related to school closures and inavailability of face-to-face supporting services that can help those kids maintain at home. So there has been a lot of need in that population. We also saw a significant increase for adolescent girls. So if you can look at the numbers, there has been 13 to 18, and especially for girls, a significant increase. And that's consistent with the data for ED visits and inpatient care. I'm going to transition now to talk a little bit about how to use some of the resources that we have to try and offer some assistance with the increased needs, and specifically with understanding that behavioral health integration is really the way of the future in terms of providing enough care for the youth who need it. How do we train and educate our residents and fellows to be able to provide this level of care once they have graduated from residency? So given that, it's quite important to have integrated care, collaborative care be part of child and adolescent psychiatry fellowship training. As I said earlier, we're highly unlikely to solve workforce shortage in the near term. So fellows training in the next 5 to 10 years are going to continue to face similar challenges of access and provider shortages. And in addition, if you look at the core training requirements, there are core requirements that can be met using collaborative care models. So using some of those models for training sites can be especially useful. So this is looking at residency education milestones. So on the left is child and adolescent psychiatry, and these are skills in systems-based practice, interpersonal and communication skills. So expecting effective exchange of information and collaboration with patients, family, health professionals, that is under integrated care. And in terms of system-based practice, demonstrating awareness and understanding the larger context of the system of healthcare, and ability to sort of effectively call on resources to optimize healthcare. All of those are met with having residents and fellows be part of integrated care models. Here at UMass, we're very, very lucky to have our fellows rotate on the MCPAP consultation rotation with Dr. Srivastava, and they actually do the face-to-face consultation and learn the difference between doing a full assessment and really just answering, trying to sort of address the question the pediatrician and the family are asking, and then bring it back to the provider. They're also involved in bridging clinic, which I will be talking about. In terms of pediatrics training, that is a little bit more difficult. They do have training requirements that could fit. So there is the need in medical home model of care to focus on prevention and on children with special healthcare needs and chronic conditions, and behavioral health conditions are part of that. There is also, again, a skill in interpersonal and communication skills and needing to demonstrate communication skills to exchange information with patients, families, and health professionals. I think the problem is that they also have many additional requirements on their time, and it is difficult to design mandatory behavioral health training for them. It is at this point mostly an elective that many pediatric residents do take the opportunity to participate in. However, it is not a requirement for training. So a little bit about the bridging clinic. So I told you about the fact that there aren't enough providers in the community. There haven't been for a long time. There aren't likely going to be providers that are enough in the near future. Told you a little bit about the model of MCPAP. The model of MCPAP really offers a one-time consultation and sends the child back to the pediatrician to receive their care there. Sometimes there are kids who need really more than one appointment to be able to stabilize. Sometimes they need more than care from their pediatrician. They really require a psychiatrist in the community to take over the care, but wait lists are such that this can sometimes take 4 to 6 months if we're lucky. So the wait time is really a huge problem. If we make a referral with our resource and referral specialist, Peter, to a community agency, 6 months can pass between the time that we did the evaluation, made the referral, and the time that the child is being seen, which is really a challenge. So the model of a bridging clinic is something that has been used in other MCPAP sites. So Tufts had a smaller site, and Bay State also has a bridging clinic model. Part of the problem with offering outpatient child psychiatry is reimbursement rates and the difficulty covering the cost of a child psychiatry in a tertiary medical center. So having child psychiatry fellows and general psychiatry residents doing their child and adolescent rotation participate is a win-win situation from a number of angles. First of all, it helps fulfill a training requirement, and as you saw before, it fits within the milestones. And the other advantage is that more than one trainee can see a child in this setting under one attending, so that makes it a little bit more fiscally possible to maintain that model. So the model of our bridging clinic is that youth that have been evaluated by MCPAP and are seen to need an additional 4 to 6 sessions to be able to stabilize and move back to pediatrician, or until their appointment arrives, can be seen in this setting. Same goes for youth who had a consultation by the Pediatric CL service, and it is difficult to find them outpatient providers to help them move to the next step in their care. So the model is such that we only provide this bridging care and then they return to the community. We've added health psychologists to offer short-term evidence-based practice therapies. We would love to be able to have pediatric residents and medical students also take part, but as I said, there are some challenges with their training requirements. And this model uses the MCPAP resource and referral and the CAN-DO resource and referral specialists to sort of help facilitate those transitions into the community. So this idea was something that received some support from philanthropy. So want to mention the CATS Foundation that started off this clinic in 2018, and then some funds from the medical system innovation funds. And when the pandemic started, an expansion through some of the behavioral health crisis funds that the system put in use for us, and more recently an expansion that was funded through the Fallon Health Fund. So this is part of the information that we share with families when we make the referral to the bridging clinic. It is a little difficult sometimes for families to navigate the system and understand what it is that we're offering. It is really important that they understand that this is not a long-term solution, that this is a bridging clinic, that we are offering short-term stabilization care until we can help them get into a different model of care. It's also important that they understand from the get-go that they're going to be seen by a trainee with an attending providing backup. And if it is for therapy, we also want to make it clear that this is not therapy that is going to go on for years. This is really a number of sessions to meet specific goals and then move past that. So this just offers a little bit more information for the family about what happens from the initial evaluation and then the referral to the clinic for bridging for either medications or psychotherapy, and when they should expect to hear back from the team and schedule the next appointment. Dr. Brown, who was the last person to do the psychotherapy, created this very nice information sheet about the type of psychotherapy approaches that are being used in this setting, and really tried to offer a lot of information for the families ahead of time about what to expect. Like many things, this also required a significant team approach. So when we first came up with this idea, Jean was kind to not only help facilitate some of the foundation funds with the CATS Foundation, but also took on being the first attending to offer bridging care. Dr. Srivastava took over in 2020. Erin Tenchny, who's currently our pediatric CL psychologist on the PDCL service, did the bridging clinic in 2019, and Ashley Brown in 2020. Liz Turan, who is CAN-DO's social worker that is in charge of triaging cases, is offering assistance in triaging to this clinic, and also for a short time provided some social worker bridging care at the early stages of the pandemic. Leanne Collins who's a nurse practitioner, is providing some additional bridging care currently, and resources and referrals are offered by Sandra Osborne. And I have to also give a shout out to Kelly Chabot, because this is actually quite complicated to make sure that the referrals from different services land in the right place and that the families are contacted appropriately and scheduled. We looked at some of the data from the work that we have done with bridging since 2019. So overall, we have seen 786 visits. The average number of visits for psychopharmacology treatment was 3. We took care of 187 unique patients. This is only a half-day-a-week clinic, by the way. And there were 24 unique patients who received an average of 10 visits for evidence-based psychotherapies. In terms of what happens with those kids, so for the first year that we did this in 2019, we looked at outcomes, and we saw that 1/3 of the kids who entered bridging had emergency department visits before they received their care at bridging clinic, but only 2 had visits after and during. One was for abdominal pain and the other one was for aggression in the home. And about 70% of the kids who are seen for psychopharm visits end up discharging to their primary care provider, which probably would not have been possible if we did not have this and only relied on MCPAP. Some open questions for the data more broadly is, does this divert ED visits, and then how many of these kids go to their primary care providers versus to community psychiatrists? Because this is estimates that we've had. Okay, I'm now going to transition to talk about MCPAP for early childhood, which is our expansion through the Pediatric Mental Health Care Access Grant. So if you remember the slides from early on with a map of states who have an established program, but also have an additional program launched in 2021, this is what we have proposed. And I want to thank Winnie Morgan for early conversations about where the model of MCPAP is really failing our youngest kids and our youngest population. And also, this really occurred from my end, where very early on in the pandemic, the calls that we were getting from MCPAP seemed to have a lot of children younger than 6, parents who were at their wits' end, did not know how to manage behaviors in the home setting in the context of lockdown. And we felt like there weren't adequate resources in the community, and our team was not able to meet their needs with what we had in place. So we started conversations with stakeholders in DPH and DMH, and looked at what was tried in the past, what is happening in the future. And what happened is that once this was put in place in terms of the healthcare access grant, we kind of had a proposal ready to go. So that was a good place to start. And Massachusetts was awarded this expansion grant for 5 years that is managed through Department of Public Health, Division of Pregnancy, Infancy, and Early Childhood, and is sort of a shared project with MCPAP. And the concept is really promoting early childhood mental health integration into pediatric primary care. And part of it is enhancing MCPAP's capacity to offer this care, but there are other pieces to this. So we have established and are training and launching our MCPAP for early childhood team. And this team will offer consultation to primary care practices, is already offering those kinds of consultations. So I'll talk a little bit about that in a bit. The other piece is creating an echo model to create practices and pediatricians who are able to be sort of like champion clinics that are willingly able to care for some of those behavioral health needs after receiving more training to do so. In addition, DPH is working with integrated clinicians to add more tools and resources and offer their own training. This is a collaboration also with the Young Children's Council. So there are many efforts that have been put in place for early childhood for a while now. And this collaboration helps it move forward. This is the structure of our MCPAP for early childhood. So the child and family, call their pediatric practice with a behavioral health concern. The practice calls MCPAP. In the old model, there's availability of care coordination, and if necessary, it's possible to offer assistance to parents by phone or to directly contact service providers to try and get them in with a clinician. There might be a phone consultation with a psychiatrist, and that might end up with a face-to-face evaluation. As I said before, the model of MCPAP really offers a one-time consultation, which is likely not enough for this age group. And I'll talk a little bit more about that when I talk about the model of consultation. What we are adding with MCPAP for early childhood is that the phone consultation triage happens with an early childhood specialist. So our new team member, Carolina, is a LICSW with a lot of experience in early childhood. When the call comes in and it is about a child who is younger before their 6th birthday, she is the one to return the call to the pediatrician with the understanding that the majority of those cases really require more behavioral health involvement rather than immediate conversation with a child psychiatrist. At that point, if necessary, she can offer face-to-face consultation, which is set up to be a multi-session evaluation and not just a one-time evaluation, and able to offer interim psychotherapy for short-term intervention. Those 4 to 6 months that it takes to get to a provider in the community in a child that is that young, it is a huge amount of time that they cannot afford, and we cannot afford to slow things down that way. The other piece is the training piece. So I'm sure many of you know about ECHO, but for those who don't, it is a model of really democratizing knowledge where there is a virtual course with providers who sign up to participate. There are set number of sessions that meet biweekly or monthly, an hour and a half. There is a very short didactic component done by the experts, but then the participants who sign up to participate in the ECHO bring their own cases to discuss them. And the majority of the discussion is really case-based. So the other piece of this model is to establish this ECHO to train champion clinics. And we're going to have the 2 parallel ECHOs. There is going to be training by our team that creates the ECHO, and that will be for the primary care providers. And then DPH is going to provide a separate training for integrated behavioral health clinicians and family partners. There's also going to be resource development, both for pediatricians and for the other MCPAP teams for treatment algorithms, as well as developing a more robust referral list for those families. So this is the team. So there is the DPH team with Larissa Mendez-Panetta, who is the project director, and Kate Roper, who is the PI. Roxanne Hogue-Chandler is the family engagement and training specialist. At our site, I'm the medical director, and Carolina Ornelas-Clark is our early childhood behavioral health clinician. Carolyn Quist-Lowen is the child psychiatrist, offering some psychiatric consultations when needed, and we're still recruiting for program coordinator. John Strauss from Central MCPAP is offering invaluable consultation. So why did we decide to focus on children under 6? So, the numbers show that there is a growing number of children in this age range who are screened positive, and there has been an increase in this positive screen. So from little bit under 9% to around 12% in the last 8 years for kids aged 3 to 6, and from 5 to almost 7, from 6 months to 2. And the tools needed to address the issues in this age group are really specialized tools. There are many issues related to attachment here, and we can't just expect that pediatricians and child psychiatrists would be comfortable doing this work without this specialty training. Pediatricians, again, are sort of the natural place that families go, especially in this age group when there is a behavioral health concern. They're most trusted, but they do need training and technical assistance. And we've seen that there have been an increase in frequent requests for consultation in this age group, and this is especially true in our Central Western region, which is why this was chosen. Another reason why this is so important is preschool expulsions and suspensions in Massachusetts are extremely high. They are a real concern, and they are especially a concern in boys of color. And the key indicator is behavioral health need. So those kids are very likely to be suspended or expelled if they were a victim of violence, if they were exposed to domestic violence, if there is an adult in the home with a mental illness or substance use, if there is poverty, or if there is parent incarceration or divorced parents or situations like that. So this is really a critically important time to intervene. And there really was a donut hole in services between age 3 and kindergarten enrollment. So Massachusetts is lucky in many ways, and it does have a robust early intervention programs from the ages 0 to 2, so until the 3rd birthday. When there is a concern, families can access services through early intervention, but they are not structured to provide emotional behavioral support. They're more structured to provide help with diagnosing developmental delays. However, once a child turns 3 and until they are 5 and start kindergarten, there really isn't anything in there. And the school systems who are supposed to do the assessments in this age group are quite strained and unable to offer supports. And especially, when the issues are related to trauma, impact, or disrupted attachments in those young kids. And it's hard to get access to care if there isn't a diagnosed developmental delay or a diagnosed behavioral health conditions. It's super challenging to find access to evidence-based treatments for children in this age group. And when there are trainings offered, it's very difficult to retain those clinicians in practices. So our current model is not enough. One-time visit is not enough. Model of care for this age group is DC 0 to 5, which is a diagnostic classification of mental health and developmental disorders in infancy and early childhood. It's back to a 5-axis formulation, but this formulation really incorporates development, relational issues, biological perspective, emphasis on observing the child and the caretaker dyad, and then validating, using validated screening tools. And so we really felt like we needed to design a system that takes all this into approach. The truth is, MCPAP tried to do this a few years back. So in 2014, there was a realization that this is an area of need and that this knowledge needs to be really disseminated. And there was a triple P in primary care initiative. The problem is that triple P is sort of a high fidelity type of intervention. And it was very, very difficult both to get primary care providers to consistently refer and sustain that. Also really difficult to get parents to complete the set number of interventions that are needed to sort of stick to the fidelity. And it was really expensive to train clinicians in this, and then there was attrition. So it wasn't continued after 2015. So our model is really trying to be more pragmatic and less sticking to a very specialized model of care, because if we feel like we cannot do that with training and subspecialty training, then how are we expecting our colleagues to do the same? Another project that really was kind of the foundation for some of the work that is going to happen with MCPAP for early childhood and DPH's work is Project Launch. And here I want to thank Carolina, who sort of educated me on this work, because she was actually one of the clinicians that worked on Project Launch. So the aims of Project Launch were to promote early childhood mental health integration into primary care by enhancing the work that is happening in clinics. So there was a clinician and a family partner. They learned that it was very important to have a family partner because it's extremely important to show support and a strong relationship with families. It is super easy to be judgmental of parents of young children, especially when you think that the way that they are dealing with some of the behaviors is not what you would want them to be doing, but it's not helpful in order to be able to help the child and the family move forward. So having a family partner in that role is critical. What happened in this was that they were supposed to be seeing a child before there was a formal diagnosis or qualifying for a wraparound through child behavioral health. But in practice, the majority of families already qualified, but they were unable to find treaters in the community. And pediatricians were sort of overwhelmed at the get-go. What it did achieve is a very significant increase in knowledge and commitment at the state level for infant and early childhood mental health overall. And it also elevated some of the workforce issues and increased collaboration between agencies, including DPH and early childhood education, because they've really implemented things and services in all environments. So in the context of family relationships and multi-generational interactions and dyadic interventions. The reason for the echo again is this really significant need for additional training for behavioral health providers. This is a quote from the work group on infant and early childhood mental health integration. This is, again, our ECHO model and developing the toolkit. The didactics and the work that DPH is going to do is expanding use of a model called the pyramid model. The pyramid model is really a designed to promote social emotional competence in infants and young children. And there is sort of a pyramid of needs and interventions, and it's all about positive interactions. It starts with having an effective workforce that is able to treat kids and parents in that approach. And then after that, there are the tiers. So there's universal promotions. So working with childcare facilities, with families to have high quality supportive environments and nurturing and responsive relationships. Then there's secondary prevention when there is an identified child with a behavioral problem. Then it's a different level of intervention that is more targeted toward offering social and emotional supports. And then there is the intensive interventions when there are actually identified needs. We at MCPAP for Early Childhood are sitting at the tip of that pyramid, at the very tip. So the kids that we have heard about so far really are outside of what this pyramid offers. However, they do have very nice models and resources available that primary care and educators and everybody working with young families can use. It is a national model, and it was developed as part of DPH, and it does promote evidence-based practices in a way that is a little bit easier to implement than the Triple P. It is available in many languages and puts a huge emphasis on having culturally and linguistically appropriate care available to families, and uses a coordinated care approach. And in Massachusetts, it's already implemented in many, many school districts and early childhood education systems, and supported by Department of Elementary and Secondary Education and Early Education and Care. A little bit about DC 0 to 5. So that is this diagnostic classification that we are going to be using when conducting those evaluations. Part of this is that the echo is not going to get to everybody, and we are going to focus on that approach in our echo with some tools from the pyramid model. But all of our consultation notes coming back to pediatricians are going to use this way of formulating, and we find that that is a helpful way to kind of disseminate this approach. So I am going to stop here and see if there are any questions.
Thank you very much. We have a couple of questions. One is from a resident wants to know, how does liability work when the virtual co-location mode takes place? Is this model akin to curbsiding, especially in the inpatient setting?
That's a very interesting question. We do not prescribe. The pediatrician prescribes. The pediatrician documents in their note that they have had a conversation with a consultant, and so they are covered for liability that way. Because MCPAP also has a lot of resources on their website, we frequently refer pediatricians to that so that they can put that in their note and they can sort of be grounded by it. In terms of our liability, I imagine that it is more than a curbside consultation because it is a formal program that receives formal funding.
There's been no test case of this, I presume, fortunately.
Fortunately.
Okay. Here's a comment and a question from Dr. Benjamin. Thanks for explaining the resources for child treatment. Very helpful. MCPAP and bridging clinics are definitely two helpful solutions to the access problem. But he's noticed that although all psychiatry residencies have to provide 2 months of child psychiatry training to adult trainees, these trainings are not necessarily done with the mindset that general psychiatrists should feel sufficiently trained to handle some, child and adolescent psychiatry problems themselves. There is no national consensus on what should be the components of child psychiatry training for adult residents. But it would seem that general psychiatrists will remain the only available psychiatrists in many parts of the country. Do you think that better training of adult psychiatrists in child psychiatry could also improve access nationally? And he said he's going to be the first to sign up.
I think so, but I think that we need to ask our PG3s who have gone through Bridging Clinic if this experience helped them feel more comfortable doing this work. I think that the answer is yes. I know that some of them have done really excellent work. That's also why I want pediatricians to do bridging, because I think that it would provide the same level of comfort. I don't suppose that adult residents will go down to the age of 0 to 5, but I think that definitely adding more robust training is a good idea.
Okay, one last question from one of the residents. What are some possible ways for mental health pay parity?
That's a big question. I don't know that I have an answer to that. I think that it's an ongoing advocacy effort, in that there have been some positive movements, but it's a real issue.
Right. Well, listen, thank you very much. It was a very, very interesting talk.
Thank you.